Hi, this is Joe Hartman of Intraoperative and at the request of one of the readers, I put together this presentation for you to give to vascular surgeons as to why they should be using intraoperative monitoring for carotid endarterectomies. There's going to be 3 points to discuss. The first is why is neuromonitoring effective, and we'll be going over somatosensory evoked potentials and EEGs in particular. Second is, does neuromonitoring actually reduce stroke rates in these carotid cases? If they don't, then we should not be running them. And third is scenarios outside of selectively shunting, where if EEG or SSEP changes immediately after clamping the carotid, then you go ahead and shunt. There's also other scenarios that can happen that a surgeon may or may not be aware of that they can use neuromonitoring to their advantage. So we'll go over some of those examples as well. So first, why is intraoperative neuromonitoring effective? Chung in 1997 showed in a survey that 90% of all carotid cases are being monitored by some modality in all the cases that are being done. So this is not something new or outlandish to present to a vascular surgeon to be using some form of neuromonitoring. And that could be EEG, SSEP, stump pressure, transcranial Doppler, cerebral oximetry. There's a whole host of things that have been done for carotids. And within the research, EEG is considered the gold standard. So that is what all other modalities are measured against. EEG reflects the metabolic activity of the brain. So any problems or alterations with energy production or an increase or decrease in supply or demand, the brain cells can have profound effects on EEG activity. So EEG ends up being a window into the functional and structural integrity of the brain. Along the same lines is SSEPs, which also monitor the electroactivity of the nervous system. And authors such as Lamb, Hopt, and Horsch have found that SSEPs may actually be more sensitive and specific than the gold standard EEG. This may be due to the fact that SSEPs can monitor both cortical and subcortical structures, since it monitors both the medial lemniscus and the parietal lobes. The branches off the middle cerebral artery, like the M1 branch that goes to the basal ganglia, could show ischemic changes that could be missed by the EEGs, which only monitor cerebral activity, which is off of the M2 branch of the MCA. Both EEG and SSEP are used to monitor electrical activity of the brain before, during, and after clamping the carotid artery. Now, in order for EEG and SSEP to be successful at preventing stroke, there must be some relationship between the brain's electrical activity and damage to the brain matter. So we look at this chart here, and this shows changes in intraoperative neuromonitoring versus changes in cerebral blood flow. There has to be some relationship in order to compare electrical activity to the brain as a warning sign for possible infarct. So general guidelines is general ischemia is seen at or below a cerebral blood flow of 10 milliliters per 100 grams per minute. Now, when blood flow is a little higher than that, at 18 to 23 milliliters per 100 grams per minute, the brain tissue is functionally inactive, but the function can be restored at any time with the reinstitution of increased perfusion, and the definition of that is pen lucida. So at any point in time, as long as the blood flow maintains that level of 18 to 23 milliliters 100 grams per minute, the brain tissue will never become infarcted, even though it shows decreased electrical activity. Now, at lower levels than that, so somewhere in between 10 and 18 milliliters per 100 gram per minute, you will see what's referred to as the Penumbra Zone. And at these lower levels, infarction is a function of time, which means at these levels, they're showing faulty functional activity. There's also beginning to structural integrity starting to break down as well. So after a certain amount of time at that lower level of blood flow, the tissue will actually begin to infarct. So it's not yet at that critical point, but at a certain point in time, if it continues down that road, it will have neurological damage. So this is when intervention becomes very important. So neuronal function is impaired immediately when blood flow drops below the threshold, or that 10 milliliters per 100 gram per minute, and the development of irreversible morphological damage is time dependent. Of course, once morphological damage becomes apparent, the initially reversible functional deficit turns into persistent defect. So even if we have a zero flow, so there is no flow going, our brain can maintain a level of integrity for up to about 4 minutes. So if there's no flow, it doesn't automatically mean that the patient is going to wake up with a deficit. In those cases, you'll most likely see severe changes and dramatically fast changes in your brain activity to where there is no brain activity, such as a flat EEG and SSEP, and those should be immediately reported to the surgeon. Now, in order to prevent these persistent defects, neuromonitoring must be sensitive enough to identify these problems early. So if there's a delay in the functional activity or electrical activity of the brain and the infarcted tissue, then neuromonitoring is not going to have the best results. So we need to look at these levels of blood flow compared to our monitoring channels. So we see on the y-axis we have cerebral blood flow in milliliters per 100 gram per minute, and on the x-axis we have time in minutes. At the very top you'll see normal function, so above that 30 milliliters per 100 gram per minute, you'll have normal function and structure of your brain activity. When that level drops in that 18 to 23 milliliters per 100 gram per minute, we're in that pen lucida. That is where the brain can maintain function, the brain will maintain its structural integrity, but will start to show changes in its functional electrical activity. But at no point in time, so it can go on an infinite amount of time without having any tissue infarct. Now we see, I've used the yellow highlighter as the area of pen lucida. The blue highlighter is the EEG area of changes. So we will begin to see EEG changes such as loss of fast activity or increase in slow activity at about 18 milliliters per 100 gram per minute. And we will also start to see loss in SSEP, which is shown in the maroon highlighter on the y-axis, at about that same level, at about 18, maybe even a lower, 16 to 18, we'll start to see these SSEP changes, and it will start to approach that 50% decrease in amplitude activity. This is important because we have gone past the area of pen lucida where it is not time dependent and there will be no brain infarct. We have entered the penumbra area where electrical activity is decreased, but there's also structural breakdown slowly happening, and over time will lead to single cell necrosis or infarction. And at the level of about 15, you'll see complete loss of SSEPs, and at about 13, you'll see a flat line of EEGs. So we will see complete loss of our modalities above the level of that 10 milliliters per 100 gram per minute, which is the brain ischemic zone, where there's complete functional and structural breakdown and membrane failure. So the pellucida, again, like we went over, is the 18 to 23, loss of functional activity but not loss of structural integrity. The tissue will not be harmed, no infarct, no problems. We drop below that and we start to see at about 18 to 20 there will be a decrease in the SSEP amplitudes. At about 18, the fast frequency activity of EEGs will be lost. At about 15, there will be an increase in slow frequency activity and loss of postsynaptic evoked potentials. So we have loss of fast activity, increased slow activity, and loss of SSEPs. At this level, synaptic activity decreases and you'll lose the brain electrical activity. At 12, you'll see isoelectric EEGs and loss of postsynaptic evoked potentials. At these levels, neuronal damage will occur if nothing's changed. At below 6, neuronal death and release of potassium into the extracellular fluid occurs. And once that potassium is released, then you have the whole cascading effect of neuronal damage. Now, if you look over to the right, you'll see in the gray zone that they have single-cell necrosis as well as infarction outlined there. Infarction is further to the right because that is more of a gross brain territory problem, where single-cell necrosis is more on the single-cell level, just as the name implies. But it also means that there are areas that are more vulnerable. So even though you might not have this huge infarct on MRI post-op, you could still have some neurological deficit at a single-cell level and have just maybe these UBOs or these unidentified bright areas on MRI. Okay, it's now to the next portion. After we've gone through the physiological reasoning of why SSEP and EEGs should be beneficial, since they match up with the blood flow levels that are critical to brain performance, we have to look at other things that go on during the case that using those modalities can also help with. So one thing selective shunting does is it reduces the need for shunting. So the problems that occur from shunting range from 0.5% to 3%, according to Sundin, On, and Conception. And the reasons for problems on shunting alone is due to typically five reasons. First, the technical problems that limit the surgeon's ability to expose and dissect the erythema, especially distal to that segment. Second is shunt kinking or occlusion due to improper placement. Third is intraoperative thrombosis formation due to it. 4 is increased risk of cerebral embolization of the atherosclerotic debris and air into the distal circulation. And 5 is potential intimal damage resulting in postoperative thrombosis at the operative site. So the solution to these shunting problems is use selective shunting and not shunt when you don't need to. And if you look at the research, EEG monitoring will show that a shunt is needed about 1 every 10 cases. It goes up to 20%, but we'll say 1 in 10 cases need shunting. So that eliminates 90% of the shunting that is done by vascular surgeons that do non-selective shunting, where they just shunt every case. Selective shunting based on neuromonitoring, particularly major EEG changes, may reduce the incidence of stroke tenfold. So, Newer 93 showed a large discrepancy in strokes versus those that are shunting everyone versus those that are selectively shunting. And other studies have shown that neuromonitoring these carotids can even come close to irreducible minimum, where the rates were only 1.1% and some had 0% infarct on their patient population. Now, a multimodality neuromonitoring strategy, which would be using multiple modalities such as SSEP combined with EEG, can afford a better neurological outcome, according to Jensen 93. And Thompson's validated that using these extra modalities is clearly cost justified, since the lower level of stroke rates have decreased the out-of-pocket expenses of these long-term cares and lawsuits and other things that come along with these severe neurological deficits. Woodworth in 2007 had a multivariate outcome analysis of selective versus routine shunting 2 out of the 194 patients, or 1% of the selective shunting group, based on EEG and SSCP, had perioperative strokes compared to the 47 out of the 1,217, or 4%, in the routine shunting groups. So patients who had EEG monitoring with selective shunting were more than 7 times less likely to experience perioperative stroke. And here is a graph of that showing the distinct difference between the selective versus non-selective shunting groups. Salvin also compared the results of routinely shunted patients in 92 carotid cases with selectively shunted patients in 213 carotid cases based on EEG monitoring. In the selectively shunting group, 16% subsequently required shunting. So the major stroke rates in the routinely shunted group was 4.4%, and it was a significantly lower level at 0.5% in the selectively shunted group. So when we're looking at these SSCP changes, you want to make sure that the vascular surgeons understand what it is we are looking at. So here's a image of EEGs. On the left is before clamping, and the cerebral blood flow was measured at 20 milliliters, which is above the level of infarct. It's in that Penumbra zone, versus after the clamping, where the patient had only 7 milliliters, which is below that 10 level. So we are in that ischemic infarct zone, and you can see that the patient actually has isoelectric channels in those frontal areas, and has severe loss of fast activity in the more posterior, all on the right side. So another thing to mention to them is they're showing a unilateral change, global ischemic changes on the right side, which is very significant of the need for a shunt. So using the bipolar montage that was shown above, the alarm criteria outlined by Kraft in 94 the changes in EEG yielded 100% sensitivity and 100% specificity for detection of ischemic episode. So these modalities that we're using are very sensitive and specific for ischemic episodes. Changes in EEG patterns have been shown to demonstrate ischemia to different brain tissue types, with loss of the fast activity associated with the gray matter and an increase in slow rhythms reflect the deafferentation of the cortex caused by white matter, according to Fott in 1993. That's important because we generally see fast activity gray matter material having ischemic changes first, which corresponds to what we see, which is a loss of the fast activity. If we look at SSCPs, we'll see the decrease in amplitude, and we'll see it in this study showing that it changed rather quickly. So within the minute, we already had a significant change with what looks to be at or above 50%. And I'm assuming at that point they alarm the surgeon starts shunting. So as they're placing the shunt, another 2 minutes goes by, and the patient is now flat. And by the time they place the shunt in there, it only takes a matter of minutes before SSCPs are regained, and due to the reperfusion of the blood. And once again, when they removed the shunt, the patient again started losing brain function, and then when they opened up the clamp, the reperfusion again restored the SSCPs. So this patient was very sensitive to the loss of perfusion of that blood flow level during that case. Alright, so here's a couple examples of how neuromonitoring can help surgical outcomes beyond just the routine telling the surgeon that they need to shunt when you lose SSCPs and EEGs up front. So first we see that EEG changes happen very rapidly for the most part. So 69% of them appear within the first 20 seconds and 80% within the first 2 minutes. And it's a pretty safe assumption that the quicker the changes are, the more profound loss of regional cerebral blood flow there is. So there's an instantaneous loss of activity. So knowing that, as well as knowing that we only have about 1 out of 10 cases that require a shunt, so if you make it past the first 2 minutes, then you only have about a 2% chance of needing a shunt in those cases. So the surgeon can continue on with the case with confidence, knowing that the brain is getting a sufficient amount of blood perfusion. So the surgeon will no longer feel rushed. This also allows the surgeon to perform routine closing of a patch instead of a primary closure, or using an ultrasound after closure, which he may or she may typically not do due to the feeling of a time crunch. When you use the primary patch over a primary closure, the studies have shown a decrease in restenosis from 6% to 1.5%, according to Archie in 2001. And that's typically due to the fact that there is a wider artery. When you do primary closure, you typically have a smaller final product of the artery, but when you have a patch, you have more room to close with, and the vessel is usually larger. So the incidence of restenosis is less. Now, using the intraoperative Doppler, it showed significant lesions in 11% of all patients, showing that the patients, after they thought they were done doing the endarterectomy and they took out all the plaque, there were some issues still going on. So they identified and immediately repaired significant defects, and it may decrease perioperative complications rates and long-term restenosis rates. Alright, the second example is, should a shunt be needed due to changes in EEG and SSEP? A return to baseline indicates that the shunt is properly performing. So we saw earlier that a shunt can be malplaced, or it can kink, or it can be non-functioning, and if the surgeon had no way of verifying that the brain was being reperfused, he or she would go on without even knowing that. So after a shunt is properly placed, EEG should return within 2 to 7 minutes on average, and it's a strong indicator that the damage has been avoided. A third scenario is if there are changes later on in the case, whereas you might be finishing up the procedure where you're closing, and it might take longer to place a shunt than it would to actually close the case, or there could be some possible damage due to an emboli. Anesthesia can be administered for neuroprotective reasons, and EEG can be used to help quantify that level of neuroprotection administered by anesthesia. So according to Doyle-Madden 99, neural activity is seen as waves of EEG of varying frequencies and amplitude sizes, and for neuroprotection you want to see isoelectric or no waves. The closer to isoelectric, the less activity and the less demand. So you go from a standpoint of not wanting to see any isoelectric activity, because that means that the brain is infarct, to these scenario where you want to protect the brain, so you're there to actually verify that you are in isoelectric state and not just burst suppression, to lower the metabolic demand of the brain and help protect it. Should an EEG or SSEP change be attributed to an emboli, shunting will be of no benefit. However, EEG could still be used to verify that neuroprotection from anesthesia. And that's the end of the presentation. I hope that this is helpful for you if you are out looking to get more business from vascular surgeons. If you do like the presentation or want some further information, please leave a post on my blog or on the YouTube, wherever you're seeing this, or rate it, give it a thumbs up, put it on Facebook, whatever. And if that's happening, then I will continue to make more of these. All right, thank you very much.